I'm going to start with this customary history slide. I've just prepared one, and as ordered by our boss, Dr. Bansi Sabu sir. So I'm going to run through some milestones which reflect the discovery to innovation pathway of diabetes research. So in 1889, pancreatic diabetes was discovered by Minkowski and von Mering. In 1921-22, insulin was discovered and purified. First life-saving treatment, and that credit goes to Banting, Best and Collip. 1959, distinction between type 1 and type 2 diabetes. In fact, honestly, I didn't know that this particular year told us the difference. So that credit again went to the researchers Burson and Yalow. And then between 1961 and 67, glucagon, insulin pump, pancreas transplant, laser therapy for retinopathy, all those landmark research came to the clinical use. And between 1976 to 78, A1C test was developed courtesy Joslin Diabetes Center, and then human insulin was synthesized by Genentech company. And between 1986 and 99, insulin pens, external pumps, and the first CGM came to clinical use. Between 2016 to 2014, inhaled insulin, stem cells, and islet implants were being introduced for clinical and research practices. And in 2016, the first FDA approved hybrid closed loop artificial pancreas system came to us for clinical use. And so at the bottom I have inserted a summary sentence. From a dog pancreatic removal of pancreas in 1889 to stem cell implants and AI driven closed loops, diabetes research has come a long way, and it continues to transform lives, moving closer to a cure. So the learning objective of my brief presentation today will be to understand historical background, recognize key clinical features. This is all regarding type 5 diabetes, which has been recently pronounced by the IDF in April this year. Then review proposed pathogenesis of this new variant and appreciate how the management and research priorities of type 5 diabetes differ from traditional types. So the first feelers regarding this new variant, so first reports of type 5 like diabetes in lean young adults with a BMI of less than 18.5. This surfaced way back in 1955, and 30 years thereafter, the WHO coined the term malnutrition related diabetes to describe such patients. And again, in 1999, because WHO didn't find support from many bodies, many of the renowned American Diabetes Association, EASD, etc., all those bodies, so it chose to remove this category due to uncertainty. So now we are faced with this question: do we now have stronger data to justify reinstating it the same, which was described earlier under a new name, which is type 5 diabetes? So the diabetes type 5 was recently proposed in the literature, very recent, this year itself, but it is not fraught without debate. The debate persists that whether it is a new distinct entity or it is being it is just a earlier one being relabeled. And so it's our prime duty to critically appraise evidence and implications of this new nomenclature. The IDF classification, typically the IDF classifies diabetes into these categories: type 1, which is mostly autoimmune, and then type 2, which is a mix of insulin resistance and progressive beta cell loss, GDM during pregnancy, and other specific types such as monogenic diabetes, diabetes caused by exocrine pancreatic diseases, which is like, for example, cystic fibrosis, also known as type 3C, and drug-induced diabetes. Recently, a type 5 diabetes classification was introduced to categorize severe insulin deficient diabetes caused by chronic undernutrition. So that's the difference. The causative pathophysiology happens to be sustained prenatal, postnatal, early childhood and adolescence undernutrition. Then this is what is setting it apart from all other types. So why old wine? Why Dr. Bansi has asked me to take up this challenge and describe this as old wine, because the same phenotype repeatedly is observed across low and middle income countries, and it has been variously called by terms like, or it has been known by terms like PDDM, which is protein deficient diabetes mellitus, MRDM, which is malnutrition related diabetes mellitus, and atypical diabetes. But at the end of the day, all refer to the same clinical picture: lean individuals with profound insulin deficiency but no autoimmune markers. And why the term new bottle? What's new is the evidence base. Modern biochemical, immunologic, and imaging studies show a distinct pattern. In January 2025, an international consensus, very importantly, it was held in Vellore, India, which proposed a unified classification, and this was further endorsed by the IDF in April 2025, and hence the term new bottle. So, what about this new name? Basically, the IDF, after pronouncing the new nomenclature, made a working group, that was formed with the aim. This group's major job was to develop diagnostic criteria, coordinate research, and advocate for context-specific, context-appropriate prevention and treatment strategies. So, we'll be briefly having look at each one of this. So, what are the key diagnostic profiles? So, you have typically, if you come across a young lean individual with hyperglycemia who has a BMI typically less than 18.5, it may be around 19, but this is classically in the description awarded to type 5 diabetes. And then there is an important history of lifelong undernutrition, which will be prenatal and during the pregnancy, postnatal, early childhood, and adolescence. So it continues. The undernutrition story is a continuous trigger. Then there will be insulinopenia. So C peptides might be miserably low, but preserved insulin sensitivity, and typically no ketoacidosis, no islet autoantibodies. So these cases have surfaced mostly from South Asia and sub-Saharan Africa, the Caribbean, and Latin America, and it is suspected that millions are potentially affected by this disorder in the low and middle income countries. So we'll have a quick look on the pathogenesis. This is the overview. So early life malnutrition is at the core of the disease, and that translates into impaired beta cell mass and function. There is minimal to absent insulin resistance, means there is a preserved insulin sensitivity, and there is a strong possibility that epigenetics and oxidative stress mechanisms also contribute to the persistence of this malady. So prenatal programming and low birth weight accompanied by childhood protein/nutrient deficiencies and infections ultimately lead to severe beta cell defect, but that is fortunately accompanied by normal hepatic and peripheral insulin sensitivity. So at the bottom I have re-emphasized that type 5 diabetes is thought to result from impaired pancreatic development caused by prolonged nutrient deficiencies. That we need to remember. Just to drive home a few next slide. In a couple of minutes I will come to that slide. Now, what is the usual clinical course? So many patients may do well, please remember, with OADs, and few of them may require insulin, but none of them are likely to develop ketosis. And there is a high risk of microvascular complications like retinopathy, nephropathy, neuropathy if the patients remain undertreated or untreated. And social determinants like poverty, food insecurity, these issues lead to delayed diagnosis and poorer outcomes. So what are the management principles? Many individuals with type 5 diabetes may be able to, as I just mentioned, manage their sugars with oral medication. Few will need injections of insulin. But it is critical to, nutritional rehabilitation is the way to go to, look after such individuals. And for that we need to screen and treat comorbid micronutrient deficiencies, And in type 5 diabetes, what we need to adopt is culturally appropriate education. This makes self-management more realistic and acceptable, thereby improving glycemic control and enhancing trust in care. So at the bottom, I have highlighted in red, we need to adapt diabetes education to the patient's language, to the literacy level, to his or her customs and his or her beliefs, instead of using a standard module for patient education. So what are the prevention strategies available to us? The most effective prevention is addressing undernutrition before and during pregnancy, as well as in early childhood and adolescence. So growth monitoring using WHO standards and integrating such screening tools into national NCD programs can help detect at-risk individuals much earlier. So that's the way to go forward. And what are the research priorities for all of us? We need universal diagnostic criteria. I mean, there has to be a consensus across the board. Large prospective cohorts and biobanks to understand genetics and epigenetics of this new, what is, projected as a new entity. And the trials of tailored pharmacotherapy and nutrition interventions will clarify best practices that we can adopt for this distinct, rather than new, it's a distinct phenotype. Now we are more aware, but it has its own quota of criticisms. It's not without that everybody has welcomed this pronouncement. People have criticized, and the basis of criticism is on these 4 points. No consensus definition. No, till to date, everybody is not happy with wholeheartedly welcoming this new terminology, and because there is an overlap with existing types. And many people perceive that it may overcomplicate the classification, and the need of the hour is a total blanket consensus and endorsement simultaneously from ADA, WHO and EASD. So my take home message, ladies and gentlemen, so type 5 diabetes is more old wine in a new bottle than a genuinely new entity. And because it is long recognized entity, and now only it has been unified as type 5 diabetes. And all of us must acknowledge the need for refined classification. We need to focus, our focus must be on patient outcomes, not just the terminology. And type 5 diabetes adds little beyond current categories, but it has the positive offshoot is that it underscores the push towards precision medicine. We are going to be pursuing in that direction. So even after sharing humbly with all of you all these slides, I am still confronted with the conundrum at the bottom, that is type 5 diabetes more of an educational shorthand than a validated category at present? The only time will tell us. So thank you very much for your patient hearing, and